Welcome back. You're watching Morning Prime. We're discussing access to reproductive health care, quality reproductive health care. We have established in the past half hour that there aren't enough specialists in the country, and there are many other barriers that hinder women across the country from getting great reproductive health care before, during, and after their pregnancies. And now we have with us in studio Nelly Munyasia, who is the Executive Director of the Reproductive Health Network Kenya. We also have the President of the Gynecology Association of Kenya, that is Dr. Kireki Omanwa. Thank you so much for staying with us. We're talking about solutions now. I'll start with you, Ms. Munyasia. Could you explain to us, in terms of awareness and education, how can this help in terms of getting health care that is good for your reproductive health?
Thank you so much. When we talk about reproductive health, it's holistic, it's communal, it's multi-sectoral. It's no longer a Ministry of Health issue, because when I remember when we started getting a lot of increase in number of teen pregnancies, and we only had the Ministry of Health trying to address this issue, we have not been able to get solutions. And what we've been saying is we need a multi-sectoral approach. We need to work very closely with the Ministry of Gender, the Ministry of Youth, the Ministry of Education. More importantly, the Ministry of Education, because we just had a conversation back then in Kakamega with some of the key stakeholders, and we were asking them, how is the return to school policy? Interesting. It's only on paper. People are not sensitized on these documents. They do not know what needs to be done. Even the girls themselves that need to go back to school after delivery. That aside, I think we need to have conversations on reproductive health right from the communities, because that's where our issues start. And when we are in the communities, we need to bring all the key stakeholders on board. This includes, of course, the healthcare providers who are technical experts. Then we have the opinion leaders that shape the reproductive health conversation in the community. We have the religious leaders who, again, are very critical when it comes to issues around reproductive health.
But sometimes they are the hindrance to...
They are the hindrance
when it comes to the young.
Yes, and that's why we are saying we need them on the table. We want to show them data and tell them these are the numbers, and we are contributing to these numbers. And for us to get solutions, we need you to support us in making sure that we are implementing the amazing policies in place to ensure that these young girls can access services, can access information. We need to break down this information in a language that is well understood and bring it, from the toppest of the level and bring it down to the community level. If possible, break it down to to a language that is well understood by the people in the community. There's a project that COGS is doing, very amazing, in the Ma community, and they have the community engagement tools, and they have broken the language to Kiswahili and the Ma language. That means that this information is getting to the recipients. So that's what we need to do, and get engaged in the community dialogues. And we don't leave the community dialogues for the chiefs only. Bring the technical experts so that they are educating the community, and then have such forums where we are talking reality, facts, collect data, and
all of this.
Yes.
Health, or
no,
multi-sectoral?
Multi-sectoral. We would have loved today to be with Daktari and have someone from the Ministry of Education also, or someone from Gender, and also have a religious person, so that we are saying that these are the problems and we need to come together, sit on the table, and address these issues. Then finally, advocacy never stops. We use evidence-based advocacy, where we're using the data that Dr. is just talking about, the 488. There's a research that we've done, and we hope that the results can come out on the effect of the COVID-19 on reproductive health. And you can tell by the initial information that we collected, a lot of teen mothers that died because of system failure. And we're just saying our health system, there's no commitment to our health system. And more so as we get into the political time, we're going to see a lot of gender-based violence cases, and no system has been put in place to address some of these issues. The whole burden, I would say that the government is leaving the burden to the civil society organizations, to the medical societies, but they need to be taking lead, and we are supposed to come on board and complement.
Okay. And Daktari, I'm sure you would rather an educated patient than an ignorant one. And when it comes to symptoms and perhaps taking care of themselves, explain to us why it's important to have comprehensive sexuality education and, of course, just an awareness when it comes to reproductive health.
Thank you very much. First of all, let me just add on to what my sister here has talked about. The church is very important. Religion, because we know that it plays a huge role in the Kenyan way of life. So I think they must be on the table as we talk about this. Now, talking about information, about access to this information, my sister here has talked very well that this information has to be broken down, into a language that can be understood, a language which is not from the ivory towers in the universities or whatever it is, a language that the common man can actually, as it were, can actually access and digest and understand and also be part of it. So information is very important. When do we start this information? That is something else which is very important. It has been an area which is quite controversial, because anytime we start talking about sexual reproductive health, people are up in arms.
Yes.
They say, oh, you want to over-sexualize our children. Oh, you want to be this, you want sexual promiscuity, and so on and so on. But actually, we missed the point. Yesterday, I got a very sad telephone call from one of the registrars. I'm on call in Kenya. And she called me and said, Dr. we don't know what to do with this patient. It's very sad when I heard it, and I see it's quite emotional. He said, we have a patient here, a 4-year-old who has been brought by the father. She had just been dropped from school in one of the estates, and the person who opens the gate to the estate assaulted her. 4-year-old. And when they started asking her, they said, Niula anafungwaga gate, so it must be the gate person at home. These are some of the things which are here with us. We need to educate our children. We need to talk to our children. Tell them, look, nobody should touch you in certain places. And if they attempt to do that, we should actually scream or do something, because that is a no-go area. That is not over sexualizing our children. That is actually protecting them. So we need to inform these children. Number 2, we talked about COVID-19 came, over 150,000 adolescent pregnancies. These have, in most societies, they have stopped going to school. They deliver these children. These are children delivering children. There are complications which come along. Their bodies are not they are not ready for delivering. They end up, having cesarean sections and so on. And again, we come back to that place. We lack specialists. Sometimes these complications of cesarean sections, we see them in the referral hospitals and so on. So education is the basis and is the key. We need to talk to these children. Actually, we should start as early as possible. And we're not telling them about sex. We are telling them about their bodies and how their bodies act and how they will behave. When they get to the adolescence, when the hormone starts bubbling and so on, they need to have information that when you get your friend starts talking about umeshafanya hiyo sijui nini, let them know the consequences. That if you are going to actually go and do this, what your friends are doing, you can actually get pregnant.
Absolutely.
And if you do get pregnant, there are consequences and so on and so forth. Pregnancy may not be the worst, actually. There are other issues which you can also get. There are sexually transmitted diseases which will be with you the whole of your life and so on and so forth. Data which came from the Ministry of Health the other day said that actually between the ages of 15 and 25, this is where the highest infection of HIV is. Is it because they don't know? Is it because they don't have information? The Bible says, my people do what? My people perish because of lack of knowledge. So this knowledge has to be disseminated, filtered down to the primary level, and then be adopted to it. And then as gradually we go up, even in university, some of the young people that we meet actually are quite ignorant about this.
And that's where abortion rates go up.
And that is where abortions are and so on. And even talking about abortion, by the way, abortions are not limited to young women only. We have married women who have children, 2-3 children, but unfortunately have gone and procured,
and that goes back to the issue of reproductive health care before pregnancy. Information. When we talk about contraception, everybody's up in arms. What are we doing? Contraception, you want sexual promiscuity, and so on and so on. But again, that is not the point. The issue is not to stop you from having
having children. Have as many children as you want, but you can actually space them the way you want. Why? Because we know that a woman, the woman's body which has carried a baby, you know, the baby sucks everything from the woman. Give that body time to sort of get back to itself, bond with that child, and then after that, then you can have another child. We are not stopping anybody from having the children that they want. We just want to help them to space these children.
Absolutely. Ms. Munyasi, earlier on we talked about the in-between. One child should not hinder you from ever, or, you know, ruin your entire, sexual or rather reproductive health. Now let's talk about community health workers. How can they be empowered to be, you know, a link between the few specialists that we have and our community? And, community health care, community health workers are recognized in the community unit, in the community strategy. Well documented, again, amazing policy that the government has. However, we do not see, again, a deliberate or an intentional effort by the government to make sure that we are making use of the community health workers. Because, and again, I want to use an example of the project that COGS is doing in the Mass Society. Working with amazing community health workers, we have built their capacity. They have the information. They conduct door-to-door, visits, provide information. When they lead dialogues in the community, they do referrals from the community to the facilities, and this is because there's COGS supporting this project. Probably there's Reproductive Health Network Kenya working in Kilifi, doing the same things, supporting community health workers, training them, providing them with the right tools, providing the IEC information, broken down into the basic language of the community, and they're able to identify, they are able to provide basic counseling, being the, at the primary level, at the lowest level of the community level of providing these services. And they know in this community we have provider XYZ, we have specialist XYZ, and they can assess and know that this one I need to take to the midwife, this one I need to take directly to Dr. XYZ. And the community health workers have contacts of all these doctors. So they call, even by the time they are taking the patients to the facilities, they call and the doctor will be there waiting. Beyond the provision of services by the doctors, midwives, etc., they do follow-ups, checkups in the home just to make sure, basics, temperature, are you over-bleeding, mama unatoa damu mingi, unaona rangi gani ya damu, unasikia mwili inachemka, umemeza dawa, nionyeshe. I remember when we started the TB project back then, they had what was called DOT, direct doc, where they did direct observation treatment, and the community health workers were very key. They followed up the women, the clients to the communities. The same thing we can do with reproductive health for the women, especially the young girls that are scared to go to the facilities because they are pregnant, because of stigma. What will the healthcare provider tell me? Because I know provider attitude has also contributed to the young people not going to the facilities. The community, they do not want to get out of the homes because the community are looking at them and saying, why did you get pregnant? You're a young girl, your mother is a pastor. So the community health workers play that role of dealing with the stigma, being the one to handle the stigma, and supporting these young mothers to access care, and even supporting these young mothers to be able to take care of the young children. They even don't know how to breastfeed, and they do not want to go to the facility because watakeleleshwa, haujui kunyonyesha mtoto, ulizana hujui kunyonyesha. So the community health workers, if well equipped, provided with the right information, they're very key in the whole care of a woman. Dr. Kireki, she's talking about the program you have with the MA community. Explain to us the link that is the community health workers and certain communities that have very specific and unique cultural practices. And we can go even into FGM and, of course, how this plays out in terms of the general wellness of our community's reproductive health access.
First of all, I think community health workers are a very important link. Why? Because, as my sister here has said, they can be equipped, to notice some things and escalate whatever problems that they have seen to the right people.
Right.
But the most important thing here, I think, when it comes to community health workers, is the trust. The community knows that this is one of us, and one of us understands us. This one of us probably has gone through the same system, and he or she has actually gone through the problems that we are actually going through, and he or she is here to support us. Even when the nurse is not there, the doctor is so far away, this person is here, and I have access to him or to her all the time. FGM, a very interesting thing that we are talking about. The president actually gave a directive that hopefully by the end of this year we should actually have got rid of FGM, which is a fantastic, fantastic thing. Now, FGM is a big problem. It's not a big problem in Kenya only. It's a problem in East Africa. It goes into West Africa, all the way even up to North Africa. It has been there for ages, and probably it will still be here after some time. Now, what we have in Kenya, we know that FGM is outlawed in Kenya because what is done is actually horrible. And in some situations, some of the patients that we see, it is actually criminal. Because what they do, they remove the clitoris, they remove the labia majora, they remove the labia minora. So whatever is left is just a small, call it a pathway. And this becomes a big problem when these women get pregnant. First of all, they cannot deliver because, again, once they have done whatever they have done, there is tissue, fibrous tissue, and this the genital area of these women are not flexible. So it becomes very difficult for them to deliver. And when they do deliver, you find they have complications. They have complications like what we call vesico-vaginal fistula, meaning there is an opening between the bladder and the vagina, sometimes even between the rectum and the vagina. You find that they labor for very long, and sometimes these babies are stillborn or they are born with complications. So we come again to community health workers. We need to talk to them, say, look, even if this has been there, it's a cultural practice, bad cultural practice, we have moved on. We need to talk to the community influencers, the chiefs, the religious workers who are actually embedded in this community, and say, look, these are the complications that we are seeing. We are losing our women, we are losing our children. Some of you men are running away from your wives because of the fistulas that they are getting, and so on and so forth. Can we come and have this conversation? It is having a conversation, not going there and telling them, you guys have to stop. Because when we do that, we'll be doing exactly what the colonialists did. They come and say, whatever practices are wrong, your names are wrong, the way your eyes look are wrong, your hair is wrong, and everything is wrong. So you have to adopt what we have given you. So we need a proper conversation. We talk with, and as I mentioned in the beginning, trust is very important. So the community health workers have this trust. Once they have been equipped and they have the knowledge and they have the numbers and they can see the complications, we can go down and say, look, this is what we have seen. I don't want my daughter to go through this. I don't want my sister to go through this. Must we go through this? Why don't we now have a sort of cultural shift, a mental shift into something else? And look at other societies. We keep on looking at Europeans and so on. They don't do FGM, but we still look up to them, with a lot of things. So I think it's just, we need this cultural mental shift, and we need everybody on board. We need the chiefs, we need the sheikhs, we need the pastors, we need the educationists, we need the midwives, we need the consultants, and we need the government. The government on board as well.
Absolutely. That is Dr. Kireki Omano, who's the president of the Kenya, or rather Gynecology Association of Kenya. We also had with us today Ms. Nelly Munyasia, who is the executive director, Reproductive Health Network Kenya. So little time, so much to talk about. I'd like to say a special thank you to our guest this morning for giving us insight into the access to health, reproductive health here in Kenya. And that marks the end of Morning Prime today. My name is Trix Ingaro. Thank you for watching and enjoy the rest of your day.